So good morning, everybody. Thank you again for all the work that you have been doing, and thank you especially for being here with us today. This is our final town hall for this school season, and I was struck by the little story I'm going to share with you. Over 120 years ago, a young woman from a very privileged background bucked the system and her parents' wishes to become a nurse. Nursing profession was not considered a profession, nor was it considered appropriate for someone of her social standing. This nurse's innovation and strength to go against society's norms of the late 1800s led her to live in the poorest immigrant community in New York City. Lillian Wald saw a need for education and health supports for immigrants, and she knew that living among them was the best way to make an impact. She set the stage for and coined the phrase public health nursing. Lillian Wald knew that the nurse was the best prepared person to provide the care and education of children and families, and she promoted that the nurse should be working in the schools. In this pandemic, planning to close one school year and making plans to safely reopen another one, your job as the school nurse is more vital than ever. And I want you all to know how much appreciation we as the executive board and the Department of Health value your input and your expertise in making sure that the children that we work with every day and their families are connected medically, emotionally, and physically with the ability to be able and ready to learn. So this morning, Dr. Brina Holmes and I are going to share with you hot off the press, currently draft number, I don't know what, of the COVID-19 Safe and Healthy School Guidance that we have been working on very diligently.
Hey, Soph, can I make a suggestion just because I'm looking at the chat? Hey, folks, I've done about 15 webinars with childcare providers, summer camps, Vermont after school, everyone working with youth, and the chat. I'm going to encourage you to, everything you're asking about so far, we're going to address. So rather than start with the energy that it's never going to work and that there's a million detailed questions, let's see if the draft addresses your concerns and then head into a space of what's missing, where can we have the debates. And so that's super important to me, because what happened with the childcare webinars is the energy in the chat started to distract from the information that we were imparting and wanted to really have conversations about. And so it's just a lesson learned that, and I wanted to start by describing the process, which Soph and Clayton and Becca and Kelly and Sharon Lee have been at from the beginning. So we really had to push and advocate that we needed a work group, which they call the task force, with pediatric infectious disease doctors, pediatricians, school nurses, school psychologists, special educators, the teachers union, the principals, the superintendents. We've got the bus guy. It's a really comprehensive group of thinkers that have been meeting every day, except for Mondays, for 2 weeks. So with that being said, I think we should dive in. We also use, just for framing, the CDC, which I'm just frank and honest with my friends here. CDC says almost nothing. It's just a nice, light guidance. Like, you should set your school up to be clean and have some hygiene, and it's difficult to use the CDC for anything but a guide. The AAP has come in with some very light guidance as well. And so what we ended up doing was build on our experience in opening childcare and summer programs, and also looking at other states around the country. We all have our favorite states that we have experts and leaders in. So Springs, North Carolina, the infectious disease guys love Oregon. I have school health leadership old colleagues in Maryland, Missouri. So lots and lots of background to that. So this is our best attempt. And the other thing I'll say is this is an iterative document. What we learned in childcare is you publish it, you get it into the hands of the people doing it, and then they tell you what's not working, which doesn't make sense, what has to be clarified, and then we revise. So it's always a link, not a PDF, because if you get the wrong PDF, which happens all the time, you're going to be basing it off something that may have changed. So the date really matters. Okay, so how do you want to, should we just start scrolling?
Sure. Why don't we start with...
Yeah, we're basing this on four very important principles. Go up for just a sec so we can talk about the... we have, oh, and I also wanted to say something very important. The Secretary of Education spoke at a press conference yesterday, and he framed up his remarks based on an old draft. It's just the facts. So please know that nothing he said is final, and that he was just trying, I think, to sort of show that we had been thinking through this, and it came out, especially about cloth facial coverings, it's different than we're recommending. So it's just going to be a confusing few days while we get this all finalized. So at the beginning of this document, we set some goals and objectives, which is the way that we like to think about this virus. You want to decrease the risk that it ever even enters the building. Once you're in the building, you want to decrease the transmission between people. And then when there are cases, which there will be, you want quick identification, mitigation, and contact tracing, so that everyone that's in contact with that person is recognized, evaluated, possibly tested, and isolated. We also are deeply committed, as you all are, to the special needs of students with physical, emotional, and behavioral concerns. We believe the crux of this whole virus from the very beginning is about communication. We say 8 times 8 ways, and you are going to play a huge role in this. And then we really, equity is the guiding principle for everything we do. So the CDC is very clear that your data can tell you as a society, a town, a county, or a state, what step you're in. And this is for all things, not just schools. And Vermont, by data, is just tipping into what's called step 3, which is we have such a low viral positive rate in our testing that we can start to relax a lot of our distancing and our, getting people back into groups and bigger groups. As you know, we're at 25, as recommended by the governor. We will be, if the data remains the same, we will likely be at 50 by the opening of schools. However, your great colleagues on this task force that have been thinking and thinking for 2 weeks would rather set a school up as though we're in 2 for the physical distancing of children in the event that we have to step back to that data-driven decision. It's pretty cool, solid thinking here. Because if you set it up as 3, with desks close together and kids moving about a certain way, and maybe even some cafeteria and gymnasiums, if you find yourselves in step 2 quickly, you're ill-equipped. And I thought this was one of the most consensus things that occurred in the 2 weeks. So there's the decision at the beginning of the document. The school buses are going to be set up step 2-ish, which means we aren't going to measure 6 feet, but we are going to recognize that we want kids to be as distant as possible. And as Soph reminds me a lot, there's good encouragement in this document. If you can drive your kid, please do. We know that sounds like an equity problem, which would set people up that can't be driven, that they're not complying with something we're requesting, and that it's not required. It's just an observation that if we can decrease the number of kids on a bus just ever so slightly, it's better. Okay, keep scrolling because we're not going to do every page this intensively. I just wanted you to see that those guiding principles. There's your list of all the people.
Oops,
And then we
sorry.
went right into health screenings. So let's get right to health screenings because I've seen some chat and I just want to explain what happened here. Somewhere between 40 to 45% of children present with fever for COVID across the country and the world. The two pediatric infectious disease doctors looked at all the literature. They recommended to the group that we continue to check people's temperatures. So I'm just acknowledging that that's the science. It's not perfect. It's not all kids, and but it is an objective data point, and we don't have a lot of objectivity in COVID. And so there's the decision about temperature. And we put it to the school administrators and SOF as well. How is this going to look? And this, after many discussions, it was decided schools are going to make their own plans about the hybrid approach, that families can do this, bus monitors can do it, or you can do it at the entry into the school building. So schools are going to have to ensure that students arriving have been screened. I imagine you will be the captain of this conversation, and then all the details follow. Where do we get the thermometers? What do we do about a kid at the bus stop that screens positive and his parents are gone? We've talked about all of that. I can imagine a world where in August, after trying to put these plans in place, we meet again and say that the logistics and the challenges of temperature checking are impossible, therefore we're removing it. We're going to stick with just health screening, which is the questions. Have you been in close contact with someone with this virus? And do you feel unwell, with a long list of symptoms? So please know, every business, every person I know is wondering about the temperature screen part, but these are children, so they have a little bit higher rate of the fever presentation than adults. And also the infectious disease doctors weighed in hard. So, Soph, do you want to say anything more about that? It's pretty complicated.
I guess I should say that initially I was like, there is no way we're going to do that, blah, blah, blah. But you know what? The science that the infectious disease folks shared, I'm like, okay, you sold me. We'll do it. We'll figure out how to do it. And the educational people on our team have said, you know what? If we have to put somebody on the bus to take the temperatures, then that's what we're going to figure out how to do. Which I really appreciated, because a lot of times we're saying, well, we can't afford that. Well, you can't afford not to is really the situation in much of the feedback that we got from the educational leadership. So I
did want to tell you a little bit about process before we go much further. So, you know, we have all of our experience with childcare, but we don't have nurses in childcare. I wish we did. So you all are going to be one of the most important, I mean, I'll just say from my bias, the most important stakeholders here to say, hey, Brina, this isn't working. But we're going to get this out first. The process today is not to have you take stuff out, because that group has been tasked with the work. The process goes like this. Today's Thursday. We have our last meeting at 2 o'clock. Brina and Dan French and Dr. Levine and our state epidemiologist, Patsy Kelso, are meeting at 5:30 p.m. to just say what has to be a governor's decision, because it's really ultimately he makes all of the final decisions about required type of things with COVID. And then there'll be a meeting. There's a meeting tomorrow at 1 o'clock, which is a bigger advisory group to the Secretary of Education that Soph also joins, that is broader than our task force. And they're going to take one last look at this. And then it's going out on Monday. And then so those of you that are asking for the link and all, I can't really do that. I mean, it's a small stretch, but not too big that we're sharing. Let's just keep rolling it. So the temperature protocol, lots to learn. Here's that very important passage. CDC is very clear that there are groups of people who are at higher risk for COVID. That it's people over 65 and those with underlying health conditions. Very importantly, CDC removed pregnancy. So that was on the list for childcare. And it's turned out we're we've learned more about the impact of the virus on pregnant women and fetuses, and it's okay. This is a large workforce for both childcare and schools, and this needs to be determined at the individual basis. Healthcare providers should be helping people assess their own risk, and that's going to be, we talked about it right at the beginning of the work group. This could lead to a shortage, and it's come up for bus drivers, it's come up for staff, teachers. And then we want everyone to stay home that's sick. Obviously, work you've done your whole lives. We are noting through our pediatric engagement that many less sick kids in Vermont right now since March because of all the hand hygiene. We are very careful to include kids with allergy and asthma. We can't have every kid with mild asthma staying home, and they are encouraged to discuss this with their docs. In the childcare arena, it's been complicated. We wanted parents to just tell childcare, I've been cleared by a doctor. Childcare wants medical clearance. We're not requiring that. I think, thank goodness for all of you, because this is the team-based care that we promote in several places in this document. We've got medical homes, we've got school nurses, and we've got families. And we have to figure out, really case by case, who should be in school and who shouldn't. And we have encouraged and reinforced with our administrative leadership that you shouldn't be making any of these decisions without your school nurses. We've got wonderful engagement on the group with Tracy Sawyers, who heads up the special education professional group. This is also Mill Moore, who works with the independent schools. He has schools around the state, maybe some of you are involved with them, that are for children with special health and behavioral needs. This section is solid, but we're committed to meeting all summer because the educational needs of kids who can't follow public health guidance or have medical conditions that make it a higher risk to be in a face-to-face learning needs to be considered as a case-by-case in a team-based way. So if you scroll down, I stole from the policy statement I wrote about the role of school nurses, that you're playing a critical role in this conversation. Soph and I are finding silver linings. We're horrified. I've been my whole career that school nurses aren't at every 504 and IEP meeting. I don't understand why you wouldn't be the key partner in all of those conversations, regardless of why. I think during COVID and post-COVID, we're fixing that. Every IEP and 504 meeting about this virus needs a school nurse. Residential programming, including residential schools, has to be talked about more in the context of colleges and overnight camps. So we're trying to make those links with Mill Moore, and those of you that work in residential schools, there's different rules if you're going to sleep, obviously. Okay, all of the stuff about what to do with a positive case is just COVID 101. It comes right out of our epi stuff. Soph's having trouble scrolling. We just went flying by it. So please know that this is the rock solid. This is the one thing we do know how to do. We know how to close off the area and get the area cleaned. People find this unrealistic. It's a pandemic. So I'm just going to say that when you see something and feel the unreality of it, just slow down and say, okay, but we're going to have to try. Next, if you want to keep scrolling. The school closure decisions are going to be made with epidemiology, and they're going to be made with public health, the governor, and the AOE. And it's likely, it's assured by our epidemiologists that we're going to be doing regional closure if needed. We are not going to make decisions that the whole state closes. So if there's an outbreak in a town or a community, poor Soph.
I'm sorry, you know what? I am just not very technical.
Okay, that's totally fine.
Are we still on the COVID?
Yeah, so that's okay. Scroll just a little further. COVID cases in schools are done. Decisions about closure, I'm done. And then if people get sick at school, we're advocating, instant separation and you have to go home. So I really look forward to you thinking on a school by school basis how that's going to look with physical layout.
I
The
might
buses, oh, go ahead.
too, that, I'm sorry, the infectious disease docs felt very strongly that 100 point, and the other pediatricians, that 100.4 was still a good mark.
Yep.
And that 24 hours without a fever was an okay opportunity to return, as opposed to the 72 that it had been with the daycare.
Yep. So that had its origins at the beginning. That was when people weren't being tested for COVID and they were sort of presuming they had it. CDC rule, safer for childcare to just say we don't know enough about what's happening, we just left it. And now with all that great infectious science, we're back to the 24 because so few kids have COVID. So assuming everyone that went home with a fever is COVID is false. And there's lots to talk about there. The bus, so here's the bus story. No one should get on the bus who's sick. We know there's going to be some kids to sneak through. And that's one of the sort of acknowledgements that there's imperfection to everything we're setting forth. Bus drivers have to wear coverings. The students have to wear coverings when they're on the bus. And the health check, oh, Clayton, am I breaking up? Okay.
So I wanted to just make sure you were aware of that, but you're doing okay.
I wonder if sometimes it's better if I call in on my phone. Well, let me know if it happens again and I'll call in.
I will. I think you're okay for now. Thanks.
We are strongly recommending a bus monitor. And we went back and forth on that, whether it should be.
While Brina's frozen, I just want to, I'm seeing some of the questions in the chat about the temperature. This is the recommendation.
The current physical space.
This is the guideline. 100.4 is an exclusion temperature. If you have other assessment ideas that when you assess an individual student and feel they need to be dismissed, that's valuable. That's not going to change. But the 100.4 for the temperature and the 24 hours returning to school after the last dose of medication, that's not going to change either at this point. So, we're going to continue to have people that follow the rules, and we're going to continue to have people that don't follow the rules. I see a question about the isolation room. We're going to get to that in a little bit. Brina keeps reminding everybody, this is a pandemic. Yes, it's going to cost money. Yes, there are things that must be done. There are other things.
Can you guys
hear me now?
Hear me now?
Yes, welcome back.
I'm trying.
Just
Sorry, but.
So Brina, you'll have to turn off the mic on your computer if you're going to use your phone.
Great. Is that better?
Yes.
Okay. I didn't mean to interrupt, so sorry about technology.
No, that's okay. I was just, while you were off, there's a lot of questions about the temperature. The temperature guideline is 100.4. It's not going to change. The 24 hours fever-free without medication is not going to change. But the assessment from the school nurse is still very valuable, probably more valuable than those temperatures. And we're still going to expect parents that are going to send their kids to school when they're sick. But you keep reminding everybody that it doesn't matter if you can't afford this. There are some things that you have to do the best you can on. There are other things that you have to make the changes in the building to make it work.
Yep.
To make it be safe.
Yeah, and we're going to, that's exactly right. I mean, we start with this being codified, and then you have it to bring to meetings to say, wait, what this says we have to do this, and it becomes iterative in the next few months. That's why we really need this out. And I'm so grateful for the way you're thinking about it all, because We have a lot of experience about this from childcare. I just really wanted to reassure you about that. Like all of the things you're wondering about sick kids and 100.4 versus 100 and who goes back, like we've managed it in childcare. We actually managed it in March with emergency childcare with people that when the virus was really it was on the move here. Right now it's really dormant. With the exception of an outbreak in Winooski, which is expected, there will always be little micro outbreaks throughout this pandemic. Okay.
Shall we move on to?
Yeah, a few more things about busing. I just wanted to make sure you knew we're going back to old-fashioned transportation rules. It's always been advised you have an assigned seat on a bus. It's always been advised that you cohort little kids, middle kids, high school kids. And our transportation rep, this guy Pat, is amazing, and he just says just go back to all those rules. And it's going to help with the buses because it won't be sort of the free-for-all that it has become with meeting. Because we need to know who's on the bus and we need to know where they're sitting, which is, according to Pat, was always true in case of an accident. I thought that was fascinating. Okay, here's the physical guidance as I described. We're writing in steps 2 and 3 because of the aforementioned request of this group that we have the fluidity between steps. When you're only in step 2, which is you're still worried about the virus, I mean, we're always worried about the virus, but step 2, you're still having cases. You work very hard on the physical distance of kids. You try to get, this would not happen in Vermont's rural schools, but it's recommended that you try to increase your routes. You think more about the drop-off and the pickup, and you create more bus stops. And in step 3, you can relax most of that. So we're going to let schools sort of work out this space between these recommended steps. I guess we can do drop-off and pickup. This is also very well worked out from our time with childcare about the signage and the hand sanitizing stations. Now, Soph's been a great advocate for you. Not every entrance has a sink. We might need a different entrance, or we might have to forego the sink and go straight to hand hygiene with sanitizing stations, all of which will need to be provided by your school. And the staggering of an arrival, schools are going to try to figure out based on just their traffic patterns and how they advise people to come and go. Caregivers really aren't allowed in the building. We did make the exception of the beginning of school and kids who experience high anxiety. That's in a different section, but that parents need to be screened and then they can walk their child to the classroom and then depart. I guess that's further down there. I don't think we have to spend a lot of time on hand hygiene because you guys are the masters of this, but it's everything. Every time you do anything, you should be washing. I will say, I'm not sure if we'll put this in now. I kind of want to now because I saw it last night in Oregon's plan. There's these, 4 or 5 general principles about COVID that everything should be framed around, which is stay home if you're sick, wash your hands, clean surfaces, wear cloth facial coverings, and stay in, groups and pods and cohorts. Okay, let's get right to it. Again, this is not our ultimate decision about cloth facial coverings, and really sorry for the confusion at the press conference. This group of your esteemed, those colleagues I mentioned, are now landing that it should be required of staff to wear cloth facial coverings in the building and outside if you can't maintain physical distance. The group also believes, based on the way we know the virus travels and the lack of ability or interest in social distancing at age 12 and up, that the cloth facial covering should be required of middle and high school kids as well, and recommended in the elementary kids and pre-K, we should say. We have a lot of experience with this in childcare. There is a lot of bullets here with caveats. We understand child development, and we know it's not appropriate for all. We understand behavioral challenges. We understand sensory issues. We understand social emotional issues. And we know those kids won't successfully maintain a cloth covering all day. We know there are medical reasons you can't do it. We know that you can't do it when you're eating, sleeping. We don't want kids to choke on strings. We would like facial coverings without ties. So we have one-pagers on this that we finalized last evening about children and facial coverings. This is hard, but I'm here to tell you it is the single best way to prevent the spread of the virus. So we're kind of stuck. Since none of us wanted this virus, none of us brought this virus, but we need to get back to school. We need to wear these darn things. Facial shields are okay. We still say cloth coverings are first line because facial shields collect the droplets and they sometimes move out to the sides and down. So Sharon Lee and your other public health nurse colleagues have done great guidance on this for the younger kids and the childcare. If you can't tolerate the cloth for all the reasons aforementioned, facial shields are a reasonable alternative. But we don't want to create some supply chain where you can't find them and you're trying to order them and they're expensive. And so it's a yes and phenomenon. Certainly certain types of children, especially with hearing impairment and speech and language folks should consider face shields first line. And the last thing I'll say is last Friday at the press conference, the governor said they're not ideal. He said it stronger. They're not really recommended. My health commissioner confirmed it, but they're okay. So there's just constant gray zone, muddy pond. And we gave some clear guidance here that they really need to go over to the ear and down to the chin. I know there's a great subgroup of the VSSNA and Sharon Lee have been working very hard with our infectious disease doctors and others to think about PPE. So we addressed it very briefly here, but we have a much deeper guidance coming. And there's going to be that's going to be a huge part of AOE's advocacy for funding for PPE. And when I say PPE, you guys know, so there's full PPE, which has a medical connotation, what you'll need for certain medically complex kids or any certain types of higher risk procedures. But PPE and to the outbreak or the response means the whole thing. You know, masks, gloves, eye protection. So all of that will need to be procured as well for bus driver, people doing the health screenings. Cleaning and disinfecting is pretty standard. You know, we've got environmental health people guiding us about this. There's a lot of CDC guidance here. And this is where some of the nuance comes in about cloth and furniture. And our state epidemiologist talks a lot about common sense. You know, you can't decide everything. So if you have a chair in a classroom, but it's a very special place where kids have some important developmental activity, then, you know, maybe keep it and wash it down or maybe remove it. And the other example we talk about a lot in childcare is rugs. You know, cloth is hard to clean. Rugs could transmit the virus, but they also, if you don't have rugs, kids slip and fall. So balance injury prevention with COVID prevention and make some decisions. Keep scrolling there. So if you're doing great now, you figured it out. Okay, but very clear principles about group size and integrity of the pod and the physical distancing. You got to keep kids in some known group with good attendance. And the maximum number will be determined by the governor. Right now it's 25, and that includes teachers. So you don't do just the kid number. We'd like kids to stay together in those groups, but we know that kids need to get up and move about. So they're going to have to get outside and then come back to that same room. We do believe reception areas are higher risk because of the sheer volume of humans that come and go. And we'd like to, we're recommending the installation of physical barriers. I talked about the cloth furniture, and then you just do the best you can. The CDC says feasible, possible, to the best extent. Their language is all loaded with that, and we're doing the best we can. Next slide, or scroll on down there. So oh, too far. Recognizing that the classrooms are going to look different, And, you know, this guidance is going to drive how people think about learning. Your education leadership and also school district leaders are going to be thinking about, if you have to have kids 6 feet apart, what does that look like? Because as we described earlier, we're starting with some of the structural pieces in step 2. There's some talk on our call with leadership that, you know, they can pretty quickly go from step 2 up to step 3, but they'd rather have that option. There's a lot of talk about belongings. We really need to keep kids' belongings separate, including lunch boxes. And the way you go to the bathroom has to be scheduled. So if you should interrupt at any point for things. I mean, I really want, you know, the communal space and large activities right now. With this iteration of going step 2 and 3, we're not using them. In step 3, you can think about your cafeteria and your gym, but not now. Outdoor recess space, we spent some time on playgrounds. You may know that playgrounds have been closed, at least public ones. We've had them open in childcare programs because we gave clear guidance on the cleaning. This group wants to recommend, and we are recommending, that playground can be used under following conditions of cleaning, plastic and metal, lots of disinfecting, and a hand sanitizing station outside. And then we just addressed a few things like public using school grounds. We have to talk more about things like voting. That really will be from the governor. And then, this is terrible, but no volunteers, no visitors, no field trips. Okay, keep going. Lots of building modifications.
Yeah, I think one of the questions that people keep asking is, what if we don't have a separate space? What if we don't have this or that? And I think the public health requirements here in this section, one reason we wanted to put them in here, and one reason I really encourage them to be grouped together, is so we can give this to our superintendents and building people, because there may need to be some construction happening over the summer to meet these requirements. There are some things that can't be good enough.
Okay, am I still on?
Yep.
Can you guys hear me?
Yes, can hear you fine.
Okay, good. Yeah, this section is where Soph's right. You really need to get this section, you need to get to the table with your superintendents and start thinking about all of this. We've got an environmental health person. Maybe you know Michelle Thompson. She's our Envision leader at the health department. She has reviewed this, and she's going to continue to review. There's one more interesting question about the reopening the buildings that have been closed and the ventilation and the HVAC. So you really do have an expert in the health department for the environmental health. I will say the CDC uses feasible over and over. So food service guidance is very specific as well. It's your own. It's eat in classrooms, and kids have their own food. There's not a traveling to go get food and coming back, and adults preparing the children's food have tons of rules, but we've been doing that all summer. And then if there is, a meal program, that you plate each kid separately. We were very lucky on this group, and I hope I mentioned at the beginning, to have a school psychologist, Cindy Cole from Champlain Valley. She is a former president of the Vermont School Psychologists Association. She's been an incredible resource. The AOE team already has groups thinking about social emotional health of kids, but broader than just in the context of COVID, right? Just like the social emotional learning. We felt compelled to put something very specifically about what this is going to feel like in recovery as we bring people back into an environment that has feels different than the way we've been living March, April, May, June. So I encourage you to read this when it comes out. Hope Monday. This is I'm proud of this section. I really like the way it sounds. We address staff and family and students. And then big section on the communication, and your great VSSNA leadership I meet with them every day, by the way, after we have the big meeting to just grapple with this. And one of the things Clayton and others have suggested, if we get a really solid slide deck between public health and school nurses that lays out the high points here and the clear, consistent, and regular communication, we can then begin sort of town halls with parents, communication with staff, teachers, whatever you all identify as the needs. And I will tell you, we do a daily phone call with pediatricians and family medicine doctors ever since the beginning. And every call in the last 2 weeks, I've said, get off the phone with me right now and call your school nurse. And several of them have said they have. So I hope you're hearing from your pediatric medical colleagues. I can't imagine doing this without them or you. So the team of a strong pediatric leader and a strong school nurse should be leading this communication. And I feel very strongly about that. So if you don't have a good doc in your community, which you can be totally honest with me about, I recognize the limitations of my field. I want to hear from you. You need to call me and say, I'm in Timbuktu. Who can help me? And I will find you a person, because there's strength in this, because this is a pandemic, right? I mean, this is a virus. It's not, it has to be led by health professionals. Okay, lots more on what can and can't be, you know, how we feel about community resource. This is important. Oh, CDC and others talk about a COVID coordinator. We think it should be the school nurse. There's been some talk in the group that there isn't a school nurse in every building. Yes, I know, but I would like to use this as an opportunity to promote the school nurse leader model from Sharon Lee and others, that find your school nurse leader to be at the level of the administration, to think about COVID coordination and your individual schools. We also know that you don't have enough of you, and we are trying to be creative about that. If we can find more nurses to do this role, we're going to promote that. If we can't, we're wondering about the Medical Reserve Corps, which is many of you signed up for, but now you have to take your name off because your job is here. The Medical Reserve Corps has tons of medical professionals, many retired, who stepped up in March and April and said, if there's a surge in hospitalized patients with COVID, I'm available. And we wonder if that group's still interested, which they are, in helping with the response. Could they help in schools? Really quickly, contact tracing. This is also just cut right out of the EPI rule book here. We know exactly what to do when there's a case. There's no decision making at the school level. The school nurse doesn't have to do anything. I promise. We will contact you. So the confirmed case gets contacted. They find out who that person was in close contact with, which has a definition. And then this contact tracing team reaches out to school administration. And if there's a cluster of cases in the school, then we'll figure it out. And then there is this very important concept in tracing that we need to know who was where when, which is kind of how education works anyway. So I'm not that worried about it, but keeping that sort of contact journal for especially the staff, and then kids should be attended. And I will say, while I'm remembering attendance, no more attendance awards, because we're encouraging sick kids to stay home. And we're working on truancy law, because if whatever that law is, which I'm sure you're familiar with, how many days a kid could be, beyond which if a kid's absent, they get in trouble. We have to be really careful about that in COVID, because we don't want anyone rushing back who's not well. I'm stopping there. We did the document, sort of. So that didn't give us tons of time, but Clayton, why don't you take over and tell us some clusters that you're seeing of questions?
Okay, so I went through and I tried to capture some of the major questions that maybe you and Soph could address. And then I highlighted a couple, and if we still have time, we'll go through a couple more. The first one is, what will the protocols be for students with family members who have tested positive? For example, will those students be asked to stay home until their family member has recovered?
Oops, on mute, yes. Household contacts, by definition, are close contacts of positive cases, and they go home for 14 days, 100%. But the kids around that kid do not. So please know, like, we are experts. I mean, we have 45 contact tracing Vermont Department of Health employees. This is all they do all day, every day. They're amazing. And they know exactly who's considered a close contact. So the biggest thing that we've noticed from childcare, and you guys are going to play a huge role, nobody panic when there's a case, especially because we know exactly what to do, but also because it's often not the breadth of what you think is going to happen often doesn't happen. Meaning you think you're going to have to close a wing of a school, and it turns out in the time that the staff was identified as contagious, they weren't even in the building that day, or that they didn't go that wing, or, you know, there's just a million examples of where we've gotten these red alert phone calls, childcare's going to close, and turns out they don't. So it's that measured trust in the public health process of testing, contact tracing. And people ask about March and April a lot, like, well, there was so much energy to close schools, close childcare. We didn't have any testing. We didn't have any contact tracing. We were just getting started and trying to fly the plane while we were building it. And that's all different now. Everyone's left their regular job in public health, including me. And we're all just at the ready. And the outbreak in Winooski is a perfect example. They have talked to every single close contact of every positive case in the last 8 days. It's extraordinary. And it would give you guys goosebumps because it's school nursing. I mean, if you guys didn't have these jobs, you should be contact tracers, because they ask about food, housing, heating, employment, violence, relationships, poverty, race, discrimination. It's like a 30-minute conversation with every person. And I'm so proud of it. So please, that whole angle of, oh my God, there's a case, is so well. I'm just glad you're not going to have to take any lead on that. I mean, we've asked that you be in the team when the contact tracer, when they call the school administration to say there was a case. And I'm hopeful that you'll be part of that thinking, and mostly about communication, because what we've learned in childcare is then you put out a really nice letter that says, we had a case in our childcare. I mean, it's just a transparent. And the other thing I'll say, because you guys, this matters so much, there's no vilifying, blaming in COVID. We don't say, oh, that elementary school, a bunch of kids got the virus, like it came from the school, or that you didn't do something right. That's not how we talk, because it's not clear always that it came that way. So I could talk a lot more about the sort of psychology of this, which is in some ways more interesting than the virus itself. Sorry, Clayton, I'm on my high horse.
No, that's great. So this next one is, I think, a consideration for temperature checks. And I think it's an important one that should at least be brought back to the team. In order to prepare for temperature checks, we are looking at a considerable expense to prepare for this. If it goes away in August, we've just wasted a lot of money. We're talking about thousands of potential dollars spent for schools. What about when we have—
Yeah, that's a great point.
And then the other part of it was, what about when we have cold weather and an infrared thermometers are not accurate?
Yeah, great thought. So you guys you're thinking all the same things that the work group's thinking. So one, we reached consensus that we're taking temperatures, and I probably shouldn't have said there may be a change, because that creates, that's challenging. But the way I see you all is, you're my team. I really hope you handle my transparency with care, because I tell you things to grapple together, and I don't have a lot of precision in my language when I speak to school nurses, because I trust you, and I know that you're able to manage the complexity of this viral conversation. But I have learned with other partners that I should be more careful. So that being said, it is difficult to take a temperature of a kid outside, and I'm having trouble picturing the bus monitor winter screen. no doubt. So does the kid step onto the first step? You know, I'm just trying what the state epidemiologist tells me every day. I call her every day and ask her a question. She says, what would common sense tell you to do right now? And common sense would be get the kid to step onto the first step of the bus and get the temperature taken, right? Or the second step. Because the viral risk is not for 4 minutes, 6 minutes, 9 minutes. It's concentrated hours and hours next to a person. So I hope that helps. It is an expense to schools. There's a lot of grassroots ideas in pediatric practice right now to get thermometers to patients, families. So that would take care of that bucket, because that's just life. Wouldn't we just like our families to have a thermometer? We're not fussy about no touch. I think we should be for bus monitors and school entry, but parents don't need no touch, because that's their, so like it truly could be a work group. And so my sort of wishing it goes away is only based on logistics. The infectious disease doctors are not likely to let me or Soph dismiss it. Unless say, like, let's just say a hypothesis, because you're my scientist. What if there were 3 more studies across, you know, China, South Korea, and Washington State that said it's only 20% of kids that present with fever? You know, something like that we might get back together and say, what do you think? What do you want to do with that information? So if you have anything to say about that, I stepped right into it. I'm so
no, ridiculous. That's okay. I think that's the best way to approach it. I get a little frustrated with the focus on what kind of thermometer do we need. You know, the infectious disease guys were so insistent that this is a piece of information that they want. Because the potential of information from it. So I think instead of getting upset about it, we figure out how it works, and maybe a month into it, like you said, maybe a month into it, things will change. I don't know.
And that actually rolls into the next question. I'm sorry. Go ahead, Dr. Holmes.
No, go.
Okay. So the next one was, can we have parent do temperature checks at home so we don't have to do it at school? Is that a possibility or something that could be considered?
Yes.
That's what all along.
Yes. I mean, you had a great advocate. We all wanted that. I find this conversation fascinating because I won't name names, but people felt like they didn't trust it. But also importantly, not all kids have a parent home in the morning, and all these things you know about your families. So the decision was 3 different points of entry where the screen could be accomplished: home, bus, or school building. And the school is going to make their own plan about that, which that's kind of the way education works. There's a lot of kind of structural stuff that gets put forth by AOE, and then it's all about local decisions and control. And so there's a few things that I've been pushing for standardization, and then someone in the group says, no, let the schools figure it out, right? So, I mean, I'm ridiculous how much I want to be in charge of the universe. So, but I believe deeply this is iterative. And someone asked earlier in the chat, I know I wasn't supposed to be looking, but about like paperwork. There's no paperwork. You don't write down a kid's temperature. This is just check yourself. And this is true when you go to restaurants. This is true when going to physical therapy, going to the doctor. This is the new normal for COVID. Check yourself. Do you feel sick? Do you have these symptoms? What's your fever? What's your temp? It's never going to be a log. It's never going to be a notebook. It's way too cumbersome. It's just not. And because of that, kids are going to slip through. I mean, this is what I just really want you to be prepared in that health way to the sort of low risk situation that we're setting up here. There's risk here. It's not zero.
Right.
I hope that's okay to say. You know, it's
okay.
I think another thing that the docs keep reminding me in the task force is, yes, we're seeing this all over the world, but just walking by someone does not mean that you have exposed them and now they are, you know, in the next 5 minutes going to get so sick that we have to call the EMT or something. we want to be, we are concerned about it. We need to be concerned about it, but we also need to, Brina keeps, not Brina, Patsy keeps saying, use your common sense.
Yeah.
Don't freak out about it. We're going to have all the information and guidance.
I mean, I honestly, I want to spend some time with you all over the summer about like our, where we're getting our information, what our demeanor is, how we communicate as health professionals, because we can go a long way to making this okay for people. But, and Sharon Lee knows, and the rest of our staff that are on the phone all day with childcare providers, schools, summer camp people, but you can't go so far that you're falsely reassuring, right? There's a fine line here of, we got this, but there's still a virus. And I think you're going to be asked, and we're going to really want you at all the tables where people have a heightened level of concern that you can bring down with knowledge and science. But also admit when you don't feel comfortable doing that and you're like, uh-oh, I don't know. I'm sure you all have tons of humility because you're in, you really are these expert health people in the middle of a non-health setting, in an educational setting. But I've had to say I don't know 1,000 more times in my whole career. And I've also had to go back to a meeting a day later and say, I said the wrong thing yesterday. I have to correct myself, or it got rethought by people smarter than me. So there's a humility to this, there's a demeanor and a calmness, and then there's also feeling like we have your back. Because what my team is going to do is be right there for you. We've got Nate, Sharon Lee, Sally Kirshner, Margaret Tarmy. All they're doing is answering calls from right now childcare providers and summer camps, and they're going to be there for you to say, I'll talk you through that the teacher's husband got the virus. Like, we're so good at it now, but it's hard to be like, wait, what? The husband has the virus, and then she needs to go home, right? Or she should never have come in, or because there's human behavior around this virus.
So
obviously.
Sorry, Dr. Holmes. So this will probably be our last question because it's 10:29, but I wanted to this is for residential and boarding schools and screening. We have boarding and day students, so trying to manage two different populations as far as relative community exposure risks. So do you have any recommendations for how that would work, or is there something that's been put into that process that they would be able to see?
Yeah, so what I would do, and I'm so happy to hear there's a health professional at independent school boarding schools that we've been hearing many of them do not have school nurses. So if you are a school nurse in that setting, you're going to have you're going to have to take our guidance, this guidance, and then you're going to have to look at like overnight camp or college guidance, which is coming, and cross-reference them, because we opted to not take on those residential differences because they're going to exist elsewhere, or they already do. But that in your spot, and you're welcome to reach out to me and I can help you crosswalk the two documents, because it is different, but it's not that different. You probably will have to health screen everybody every day. Unless you're in, full locked, unless the kids that sleep there don't physically leave. But even then, I have to think about that.
Okay. So, Go ahead. Okay, so
I was going to say, it looks like we're out of time.
We are.
Thank you so much. No, don't be sorry at all. Thank you so much for your time this morning, your willingness to answer questions, and all the hard work that you've been doing with all of your different teams to help.
Yeah, we should do this again, though, guys. Like, once we don't have to scroll through, I'm going to make fun of Soph for a little while about the scrolling. But once we don't have to, get the content out in such a weird, that wasn't ideal. I really acknowledge that. Let's do this again and just air it out. Like, this is, Sharon Lee and I are so excited that we have you, because it's very hard to do this without nurses. And, but we also don't want you to feel like that means you have to know everything, because it has truly taken 3 months to understand. And I still don't understand everything, but I'm doing my best. So, okay, team. Sorry for the compressed time. Talk to you soon.
Thank you very much.
Thank you very much.
So just for everybody, this has been recorded. The recording, I hope to have it done and up and posted by late this afternoon, if not tomorrow morning. We will get the Q&A to Sharon Lee and to Dr. Holmes. And so we'll also be taking these, and the responses to the questions will be based off of the final document instead of what we saw today. So we can make sure the answers are the most recent answers that can be sent. But thank you for all the questions. They've all been captured from the chat box. We'll get them into a document, and the Q&A will be sent out as quickly as we are able to consolidate all the answers, and we'll get them out to you. So
Thank you all.
Yeah, this is the highest attendance we've had at 237. It's very awesome. So thank you for everybody for your interest, and we do want to definitely get this information out and share it with not only school nurses, but with administrators, superintendents, maintenance folks, whoever needs to know this stuff. There's a lot of important things in here. So thank you.
It's terrific. Thank you all.